So now we have Dr. Athanassiou to set up our lumbar drain demonstration.
Hello, everybody. My name is Nicolas Athanassiou, one of the cardiac anesthesia faculty here at Houston Methodist Hospital. In a minute, I'm going to go in the back where I have set up a table with what we use for the spinal drain. Most of the things related to why we use the spinal drain has been covered, and about the anatomy, I just would like to say a couple of things before I go back there. One is that it was here in this hospital in 1953 that Dr. DeBakey and Dr. Cooley did the first aortic aneurysm repair using an aortic graft. And there's been a lot of improvements in the open abdominal aortic thoracic and abdominal aortic aneurysm since then, as well as the last few years with the endovascular repair. But unfortunately, still one of the most dramatic complications, which is the paraplegia, is still there, and it is quite high. As Dr. Bavares said, in the open procedure it can be up to 14% or sometimes maybe even 20%. At the endovascular, less 6%, sometimes 8%, and it can get worse depending if it's more extended, more than 20 centimeters, or if there's been prior abdominal aortic surgery that has already compromised the perfusion from below and the regional contribution to the anterior and the posterior spinal arteries. So I'm going to go in the back and start showing you. I'm going to be on live camera, and I'm going to be projected here on the screens. I've never been on a live camera in front of an audience before, so let's see how that will go. Thank you. Turn it on. Can you hear me? Okay, great. First of all, I'm going to put some gloves. They're not sterile, but obviously this has to be done with maximal sterile barrier technique, gown, gloves, mask, hat. The reason I'm putting the gloves is because I don't know with the wire. I've never put it without gloves. So I don't know if I can, even if it slides too much with my hands. So there are three things that need to be set up in order to be able to put this catheter. One is first the transducer. Second is the bag with the little chamber and the bigger bag where the CSF is going to drain, and these two need to be connected. These are normally done. We have the luxury in our hospital to have the anesthesia techs doing that, but I'm not sure in every hospital that this is happening. And then finally, you have to set up the spinal drain, which is something that is done only by us and has to be done totally sterilely. The kit that we use for the bag and the catheter is a company called Integra. We've been using it for many years. There are other companies that do similar things. So for us, it's been working for many years, so we haven't made any change. So now I'm going to start with the transducer, which like any other transducer, it has the connection for the cable, and it has this extension that gets connected to the bag, from the bag, the other extension that connects to the catheter. It needs to be flushed, and unlike the other transducers that we set up for the invasive lines like CVPA line and PA pressures, whatever, we don't use a pressurized bag for that. What we use is we get this preservative-free normal saline. So either the anesthesia tech has to give me the bottle and I draw it sterilely, or they put in a little bowl, and again, I do it sterilely. Well, for this, it doesn't really need to be sterilely, but the fluid has to be preservative-free, sterile, normal saline. So after you draw it, you have to get to the back. That's where normally the pressure bag will be connected. So this time there's no pressure bag. You have to make sure that there's no air. So you keep this lifted up so the air goes up, and you start flashing and flashing, make sure there's no air until there is, okay, sometimes you may have to tap a little more, still some bubbles coming, and then you turn this off. And so this is with the transducer, and then you put it, at the level, depending where you read, they say either the middle of the brain, which would be about the level of the ear, or the middle of the right atrium. But on a supine, flat patient, usually this level is about the same. So then, so this is the bag, and it has a smaller chamber and a bigger bag. So when you drain, and you need to be more specific and accurate on how much you drain, you have to have this three-way closed. I don't know if you can see it. So that doesn't drain to the big bag because you cannot measure very accurately. And also you have to have this vent up here open like it is now, because if it's closed, it's not vented. And with this closed and this closed, it's not going to drain in there. It had happened to me on a perfectly working CSF, and it was drain. It was not draining until I figured out that was what I was doing wrong. So this is how it comes from the kit. It has this tube here, which is blue, and basically blue means to the patient. So from the patient to the bag. It has a three-way, which, let me just tear this off. This three-way has a little cap that you take off, and that's where you need to connect your transducer. So the three-way can open either to drain from the patient into the bag. So this is how this is connected. This is the transducer, and this is the flashed pressure line. And or you can, so you can either have the transducer and monitor the CSF pressure, the ICP, which is what you should do most of the time, and you only open it to the bag to drain when you want to drain. And the bag has to be lower, but we don't, there is a way you can make it so that it automatically drains. You keep it open at all time if it goes above a certain level, but we don't trust that method, and we don't do that. So we totally control when we want to drain. We look, we start draining, we look at our watch every 3 minutes. I have a timer, and I look how much I drain. We don't drain more than 10 cc's at a time, and no more than 15, 20 an hour, unless there is severe neurologic complications, and you want to do that. So as I flashed this earlier, I want to flash a little more to get into the three-way, and I flash a little more until it goes all the way to where I'm going to connect to the patient. And then I'm turning this off again. So this is ready to be connected when we put the catheter. So this is what the anesthesia techs are doing. Let me show you what we are doing. So this is how the kit comes. It has a wire. It has this catheter, which is 80 centimeters long. It has a 14-gauge Tuohy needle, and it has these two little things. Let me just put against the darker. So this is the connector, which you have to put into the catheter on the distal part so that you can attach it to the tubing. And this is the little kind of case that you put it in as it comes out of the skin. Interestingly, as I was presenting this, I was getting ready to present this and get it ready. I looked at some YouTube videos, and someone was suggesting to use an epidural kit to steal the transparent drape that shows you the whole back of the patient, and it's better to, easier to see the midline, because usually we cover with green towels, but it's not very clear, especially in obese patients, where the midline. So I think I'm going to start using this. It's much better. Also, if you want, you can steal from the epidural kit this little foam that you put the epidural catheter, and you can use this instead of the little white thing that I showed you. So the catheter, before placing it in, you need to make it a little stiffer. And you need to put the wire in. In order to put the wire, it's not as easy as it sounds. You have to I had another syringe here. That's okay. This is not the preservative-free normal syringe, but it's the same thing that you do, as I said earlier. So you take this little connector. So you have to identify which end of the catheter is the one, the proximal, which is the distal. So the distal part, and I'm going to, again to put this against this screen. I don't know if you can zoom here as much as you can, OB. So the tip of the catheter is not open. Actually, it's occluded. And then right above that tip, there are two sets of holes, and that's where it drains from. So these holes go up to 4 centimeters from the tip. And so when you put it in, so these are, I don't know if you can see the little holes there. They're a little small. I'm going to leave this here so that you can come and take a look during the intermission, those of you who want. So the length of the needle, and then there are some black marks here. There is 2 dots. So this is 10 centimeters from the tip, and then every other single mark is 2 centimeters. The length of the Tuohy needle is 12 centimeters, so up to the first single mark. In order to drain and not have some blood or not have interrupt drain, you have to make sure that the catheter is well enough into the subarachnoid space, because if it's barely in, or if a couple of the holes are in the epidural space, you may have some bleeding and start having some blood-tinted CSF, and you start worried, oh, do I need to send the patient for a CAT scan, which is just from local there. So it has to be at least 4 to 8, 6 to 8 centimeters. Some aortics, they say 10 centimeters past the tip of the needle, so that these are well into the subarachnoid space. So let me show you how now you can make putting the wire easier. So first of all, you have to have the catheter straight. Then one trick I use is lubricate with a saline. So I just go where this wire is, and I just put the needle there. You can screw it, and you can flush it until there's fluid coming out. And you do the same thing with the catheter. So you take the little connector that I showed you earlier, and after you've identified which is the proximal and the distal tip, you get to the proximal one. And you have to be careful when you do this, because you don't want to perforate the catheter if you just go at an angle, because if you do that, you start having CSF leak, and this is very bad because the nurse will be calling you, and it's going to be a major ordeal for you. So you can see how the droplets are coming out of the little holes. And so now that we have lubricated both with saline, you can start putting the wire in. I mean, you can leave your little connector here for now. And it has to be straight when you do that. And there is some resistance. It doesn't go always too easy, but you can kind of, actually this one is going easier. But it's like a glide wire, so you have to make sure that it's not your fingers sliding on the wire, that the wire is not really advancing, but I think it is advancing. Here, and at some point you'll feel there is resistance because it reached the occluded end of it. And I think that's where you have to be careful as you're doing this to make little steps from up top here, because if you make a bigger step, you can kick the wire and then make it much, much higher, more difficult to do, and also more difficult to pull it out, which is difficult already by itself. So now you can see that the catheter is stiffer than it was before. It's not as flimsy. So now we are ready to put it in when we get the CSF. So there is not a consensus on pretty much anything with the lumbar drain. When to put it, what position to put it, when exactly to send the patient for a CT scan if there is a bleeding, when to cancel the surgery if you have blood back when you're putting with the tuohi. So every institution has their own policies. So you can, some places they put the catheter the night before, but this means you have to have the patient in-house, then it's more expensive. Plus, there is a risk for infection, there's a risk for it to stop working before you even start it. Others, they put them in the OR with the patient away and either sitting or on lateral position. We prefer to put the spinal drain after the patient is asleep and all the lines are in. We position them to right lateral decubitus position, and we try to make them have like a fetal position. We bend the hips and the knees and try to bring them towards the chest, and we try to push the back and the head towards the knees to try to optimize the space. As Dr. Scheinbaum said, we go usually either L3, L4, or L4, L5. And as the patient is on the side, the bevel of the needle is aiming laterally to the patient because the dural fibers run from cephalad to caudal, so you don't have the bevel towards the head because then you're going to cut them. Whereas if you go like this, you basically go in between and you don't cut them, so there's less risk for CSF leakage later. And after I'm in and I have a good flow, I can turn it like this so that my catheter goes up. As I said, it's 10 centimeters the length, it's 12 centimeters the length of the needle, but if I haven't done it for a while, I may forget. So I always like to refresh my memory, and I always put it in and I see where my tip is. So you see it's the first little mark after the 2 marks, so it's 12 centimeters. So when I have good CSF drain, you have to put your finger because it's easy to drain a lot because it comes pretty with too much momentum there. And so you start advancing and advancing. I can see the holes here. I don't know if you can see them. Right there, they're past. So this is the 4 centimeters, about 4 centimeters, and I'm going to advance even more. So as it is like this, I'm advancing it. So this is the 4 centimeters now, and I'm advancing. So I'm about 18 centimeters here. So this is about, I would say, 4 centimeters or 3 centimeters from the upper end of the hole. So probably I'll advance it a little more. So I'm at 20 centimeters at the end of the needle. So this is about 8 centimeters into the space. So now you have to be very careful. So it's time to take this little connector out. And you hold the catheter there and you pull your needle out. And after pulling the needle out, this is the hardest part actually, because this wire is kind of sticks inside the catheter, and if you don't hold it tight and you don't gently pull it, you can break the catheter. Yes, so someone can hold it from, usually I'm the one holding it, and someone else is grabbed, and sometimes you need to wrap the wire around your fingers, start pulling, and it's better if it's straight, and it's slowly, it's coming much easier out now than in reality, I have to tell you. And if there is resistance and you pull too hard, you can both break the wire, or it stretches so much the catheter starts making holes, and you'll be having leakage everywhere, which is a disaster because you have to start all over again with a new catheter. So it came out here very easily. Then, I'm sorry, it's on the floor, I'll put it back on. And then you put your connector here. Again, at the very, let me just go against the darker background. Here, and you have to push it all the way in. Again, make sure it doesn't angle, it doesn't make a hole anywhere. And then remember this blue tubing that goes from the patient to the bag. It's already close to the bag there, so you connect it here. And then, so remember, this part between the three-way and the bag is not flushed, and you don't need to flush it, the bag here. Because when you start draining, you'll be able to see the fluid slowly, slowly coming here, and then you know that you still have a good flow back. And I leave my 3 cc syringe attached until I connect it, and then when you're sure that it drains well, you turn it off towards the bag so that it doesn't drain anymore. You can continue transducing, and unless you really, your ICP is high, you just leave it like this and you don't drain. And that's what we do throughout the case. If there's any groove in the back of the patient's back, better try to place keep the catheter in that groove so it doesn't get compressed and obstructed. The other thing we do is we get a 2-0 silk stitch there, and this connector we find at the end of the catheter, we kind of tie it around it and make it tight so it doesn't get disconnected easily. And we use this sticky spray, and we use this kind of Medipore, and to tape it so it doesn't come off, and we use big tegaderms. And that's it. So I'm leaving everything here so that you guys can see, and the catheter so that you can see, those of you who didn't see very well, the holes, and you can measure the distances.
Thank you very much, Dr. Athanassiou.
You're welcome.